Welcome, everyone. We're going to start the event today. This is the 10th Annual Children's Environmental Center Winter Symposium. Our theme today is Decade of the Developing Brain. We'd just like to thank everyone for coming, all the different communities, physicians, Mount Sinai folks. Thank you all for your support. We're over 200 people registered for this conference, so it's actually our biggest ever. And so we're very excited today. We have a great group of speakers. And I'm going to actually start today by actually introducing our moderator. Oh, I'm sorry. Is this better? It seems to be on. Okay. Well, I'm going to thank everyone for coming. And we're going to start with our moderator today, Dr. Maida Galvez, who's going to introduce our speakers and also speak to you briefly. Thank you, Maida.
Good morning. Can you hear me? Yeah, great. Thank you, Dr. Wright, and thank you all for joining us today. We are really thrilled to be joined today by our esteemed guest speakers who will be sharing the cutting-edge science with us all today. I want to begin by thanking our top-notch planning committee. So I want to give special thanks to all the folks behind the scenes who made today possible, including Carla Azar, Megan Markham, Chris Euler, Renu Nadkarni, Raz Paupa, Marissa Bolanos, Luce Gell, as well as Drs. Perry Sheffield and Sarah Evans. Also want to thank the CEHC board, who's been a great supporter of Mount Sinai, and Rhonda Shore had reminded me today that it's been 10 years since the inaugural symposium. Time really flies. I am thrilled to welcome Siobhan Skinner, a public health nurse who will be co-moderating with me today. Ms. Skinner is Director of Patient Services for Little Sisters of the Assumption Family Health Service. And since 1958, this East Harlem-based nonprofit has been committed to helping families meet their most fundamental needs, whether it's food, clothing, health care, or a safe and healthy home environment. And through home visits, support groups, classes, and more, they help the most vulnerable achieve the wellness and strength they need to overcome everyday challenges. We're really glad to have you here. Just a few housekeeping items before we begin. There will be a Q&A session after our last speaker today. We encourage you to write down any questions you have for the speakers and turn them into the check-in table during the break. We'll collect all remaining cards after the final speaker. And for anyone watching via the live webcast, we're also able to take any of your questions during the Q&A, and please submit them if you have any. This is the most important reminder. Please take the time to fill out our evaluation form that you received to check in. This helps us in planning future educational activities, and we genuinely appreciate your feedback. If you are receiving CME credit today, you must return the evaluation form. And lastly, there's no need to take notes. The speakers' presentations will be emailed to you after the event, along with a video recording of all the presentations. Today's event will be live tweeted. How many tweeters do we have in the audience? So for all you tweeters, the hashtag is #developingbrain. So please use that when you tweet. And for folks looking for Wi-Fi access, the Wi-Fi password is a check-in. And so that takes care of all the housekeeping business. And now I'd like to introduce our first speaker. I'd like to welcome Dr. David Bellinger. Dr. Bellinger is a professor of neurology and psychology at Harvard Medical School and also holds an appointment in the Department of Environmental Health at Harvard School of Public Health. His work at Boston Children's Hospital has spanned more than 35 years, including as consultant to the Pediatric Environmental Health Specialty Unit, as a senior research associate in neurology, and senior associate in psychology. Authoring more than 350 papers and the co-author of several books, his major research interests are on the developmental impact of early metabolic and chemical insults to the nervous system. Dr. Bellinger participates on several committees, including the CDC's Advisory Committee on Childhood Lead Poisoning, as a consultant for the FDA's Neurological Devices Panel, and on the National Research Council National Academies Committee on Inorganic Arsenic. Internationally, he has worked with the World Health Organization, including as chairperson for the WHO guidelines on the prevention and management of lead poisoning, and as a member on the WHO Expert Advisory Panel on Food Safety. He serves as editor-in-chief of Toxic and is currently president of the International Society for Children's Health and the Environment. Please give Dr. Belanger a warm welcome.
Thank you very much, Maida, and good morning, everyone. My comments are going to have to do with risk communication. I don't think that as a field that we've done a very good job or an adequate job in communicating to relevant stakeholders, which include politicians, journalists, community members, the impact of chemicals on children at the societal level. And so I want to propose a way that may get us a little bit farther along in communicating the importance of these exposures for children's well-being. So just to review, the ways we typically now communicate the impact is usually statistically. We talk about regression coefficients and say, you know, every microgram per deciliter increase in lead reduces a child's IQ by half an IQ point. Many people, often clinicians in particular, look at that and say, well, big deal, who cares about that? That's not really very important. Or we report an odds ratio, say that the odds of ADHD are increased fourfold for children with a blood lead above 2 microgram per deciliter versus a level below 1. And a lot of people have trouble interpreting odds ratios, and of course the interpretation depends upon the background prevalence of whatever disease condition you're talking about. 4 times a small number is still a small number. So I don't think it really conveys what's happening at the societal level. There have been a lot of attempts in recent years to express monetarily the cost of chemical exposures. And this is moving us a little bit more towards a societal level. So we see these cost-benefit analyses. If we don't do anything to control bisphenol A, it's going to cost us $3 billion a year, and so on. And, you know, the bottom line is what some of these relevant stakeholders respond to. So it's important to do these kind of analyses, although on a moral level, I find it kind of repugnant. And then there's moving even more towards societal level of impact, there's the WHO burden of disease approach. And I'm going to talk a little bit about that because it's becoming a very common way of trying to capture the cost of not only chemicals but other sorts of health conditions. So this involves what I call a disease-oriented approach. And it estimates the burden, the health burden that accumulates if someone dies or meets criteria for a disease attributable to some exposure. Now, the steps involved in the GBD approach, first you identify the disease model, what diseases are attributable to an exposure. And importantly, these diseases have to have an ICD code. Then you estimate the overall incidence of disease in a population, and then the proportion of those cases that can be attributable to the exposure. So this is a population attributable fraction. Then you determine the case fatality rate and the age of onset distribution for the disease, and this enables you to calculate the number of years of life lost because of that exposure. This is YLL. Then you determine the duration of disease and the severity. There are disability weights that you can assign. So being blind has a larger disability weight than a broken arm, for instance. And this enables you to calculate the number of years lost or number of years lived with a disability of a given severity. And then you just add up the YLL and the YLD, and you get the disability adjusted life years, or DALYs as they're called. And then you can do this by country, by region, sum them up, and you get a total DALY count for the entire world attributable to the exposure. So I did this for WHO for methyl mercury exposure, and the first problem we run into is that IQ loss due to prenatal exposure is the primary health outcome of concern, but IQ loss isn't a disease. There's no ICD code. So what we have to do in order to fit a chemical into this framework is to estimate how frequently IQ loss due to methylmercury exposure will result in intellectual disability in a child, or an IQ less than 70. So basically what we're looking at is how many people are going to be pushed across this line of 70 because they've been exposed to methylmercury. I think you can already start to see why this kind of approach may not be very suitable for the chemical exposures that we're interested in. So I went through this process for methylmercury, and I came up with, this is the incidence of intellectual disability per 1,000 population for all the WHO subregions. And the subregions, like Africa, is divided into D and E based on child and adult mortality data. So E is worse than D in terms of health. And we can calculate the incidence by subregion and then calculate total number of DALYs. So what we see here is worldwide, most of the DALYs are contributed by the Western Pacific region, B. Although on a per capita basis, it's the region of the Americas, Bolivia, Peru, Ecuador, where the incidence rate is actually greatest. And you can make very nice maps, global maps, that tell you where the greatest density of methylmercury-associated intellectual disability is. But what this fails to capture is the fact that there's burden attached even if a child's IQ does not cross the threshold of 70. We need, I think, we need to take account of what's happening in other parts of the outcome distribution. And we've done that to a little bit. Well, we've applied that GBD-like approach to chemicals. This is something that, a figure we published 35 years ago, where we had cumulative frequency distributions of verbal IQ for children stratified by the amount of lead in their baby teeth. These are the high lead children, and these are the low lead children. And we did, in fact, consistent with the GBD approach, find that the percentage of children in the high lead group who had an IQ below 80, verbal IQ, was 3 times greater than among the low lead group. But we left it at that. And it took me some years to look at the rest of what's going on here. These cumulative frequency distributions never overlap. And this is where most of the children lie. And this is the burden that we need to capture. We don't want to ignore the children with extreme values, but we want to capture what the impact is of being shifted in this portion of the range as well. So we need to take account not only of the effect size, the 0.5 microgram per deciliter increase per microgram per deciliter, but also the prevalence of the exposure. And the best example I've come across to illustrate the importance of distinguishing those two is looking at the relationship between maternal age and the risk of Down syndrome. So here's the incidence, Down syndrome cases per 1,000 births. The incidence is about 50-fold higher among women who are above 44 years compared to below 30 years. So we know this is very well known. So on an individual basis, this is where the major risk is. But younger women are so much more fertile, higher birth is much more frequent among these younger women, so that in fact births to women under 30 account for about half the cases of Down syndrome in the population. So if we wanted to control Down syndrome at the population level, we would be working up here, not down here. And I think the same applies to chemicals. So I tried to develop an approach whereby we could combine the exposure distribution and the effect size to calculate what's the total number of IQ points lost in the population due to different exposures. Not just focusing on children with the most extreme biomarker levels of the chemicals, but looking across the whole distribution. So I went to the NHANES, got the most recent data on the blood lead distribution of children, and here are the different percentiles. And I went to the literature and got dose effect information from the pooled analysis that Bruce Lanphier spearheaded, combining the data from 7 prospective studies, including about 1,300 children, and made some assumptions about how much IQ loss would be seen in different portions of the blood lead range. So in half an IQ point between 0 and 10, and then above 10, I assumed a loss of about 6 points. The 5.1 points below 10 plus 1 more point for being between 10 and 20. And then I calculated how many IQ points would be lost for children in different portions of the blood lead distribution. So between the 0 and 50th percentile, where half of U.S. children lie, there are about 25.5 million U.S. children below age of 5, multiplying the IQ loss by the midpoint blood lead level by the number of children comes up with the total number of IQ points lost. And you can see that the total is about 23 million points. And what was most striking about this is that almost half of the IQ loss is among children with a blood lead less than 2 microgram per deciliter. And that's because this is where 19 million of the 25 million are. We know lead has no threshold. All children are contributing something to the total IQ loss. So this, to me, says that we need to augment our focus on children with extreme biomarker levels of lead and focus on reducing the entire, or pushing the whole distribution of blood lead to the left, because that's where we'll have the biggest impact in terms of reducing morbidity. So I did this kind of analysis for a variety of different pediatric conditions and events to see, where does this 23 million fit in when we talk about brain tumors and traumatic head injury and that kind of thing? Because often people will say, well, these chemical effects are so modest, we should be focusing our resources on the conditions that really have the greatest amount of morbidity associated with them. So I went to the literature and found meta-analyses of the IQ loss associated with a lot of different events and conditions, and then also estimates of the incidence or prevalence, or for continuously distributed exposures, the distribution. And I went through the same calculation as I went through for lead. And this is what I came up with. Brain tumors account for about 37,000 point loss. An individual child who has a brain tumor has a decline of about 1 standard deviation in IQ. But fortunately, brain tumors are pretty rare. So they don't contribute much to the population IQ loss. Same with congenital heart disease. A child with a single ventricle hypoplastic left heart has about a 12-point IQ decline, but the incidence is only 4 per 10,000. So on a societal level, the implication isn't so big. Methylmercury was about 1,400 IQ points. Organophosphate pesticides around 19 million. And here's the lead, and preterm birth was number 1. But these chemicals are pretty high in relation to these other factors. So I think this kind of approach is not perfect, but I think it's useful. It's useful in terms of prioritizing the risk. Which chemicals warrant further study? So we could look at the early studies of the polybrominated diphenyl ethers or the OP flame retardants, bisphenol, phthalates, and get a sense of how important is this on a societal level by combining the exposure distribution with the effect size. You can also look within a population to see what the per capita impact is of different events and exposures. So for methylmercury, if we look at sorry, I repeated IQ, but we see that the per capita impact is pretty modest, about 0.05 IQ points for each microgram per gram increase in prenatal mercury exposure. Well, if we do the same thing for lead, we see it's about 20 times greater, even with the success we've had in reducing population lead exposures. So methylmercury is very important in other parts of the world, but it's not as important here because as a population we don't eat a whole lot of fish. You can also use the approach to predict the impact of intervening to reduce exposure or the cost of not intervening. So I went back to the NHANES 2 blood lead distribution, which was back between 1976 and 1980, carried out the same calculation as I did that led to the 23 million IQ points, and I found that back then lead was reducing IQ in the cohort of children under 5 by almost 120 million IQ points, which means that all the public health interventions that we've done over the last 40 years have essentially resulted in a savings of about 100 million IQ points. That doesn't strike me as trivial and maybe a useful selling point in trying to convince legislators of the wisdom of controlling these exposures. You can also use the approach to compare the relative importance of an exposure in different regions in the world. So I mentioned in the U.S. the per capita impact is about 0.05 IQ points per child. In Japan, I went to a study that looked at a sizable number of children and yielding a reasonably nationally representative estimate of the distribution, and found that the per capita impact was about 10-fold higher than in the U.S., about a little more than half an IQ point per child. And then in Brazil, the reason mercury is an issue here is people use mercury as an amalgamator in artisanal gold mining. They burn off the mercury to recover gold, and it leads to widespread environmental contamination of water bodies where a lot of people fish, subsistence fishermen. And so using data there from the mercury distribution, I came up with a per capita impact of 10-fold greater than Japan and 100-fold greater than the United States. So this is clearly an impact at the individual child level that people in Brazil and other parts of the world where this kind of activities carried out should be concerned with. So in terms of conclusions, I think traditional approaches, the disease-oriented approaches to estimating global burden, are not appropriate for environmental chemical exposures. They lead to underestimates. When we're looking at health burden associated with what you could call low morbidity but very high prevalence exposure, we will underestimate the burden unless we come up with a method that combines both effect size and the distribution of exposures, and not just focus on the small percentage at high risk due to their extreme high biomarker values. And this is really exemplified by the former CDC use of action levels to triage children as on an individual level that's appropriate, but on a societal level, I don't think it is. Now, of course, it's more complicated than I've presented because how the distribution should be incorporated depends on the shape of the dose-effect relationship. For lead, as I say, there's no threshold, so every child is contributing something to the societal IQ loss. That wouldn't be the case if there's a clear threshold below which some chemical is safe. So I would argue that population-oriented strategies might be more effective in communicating to stakeholders the risk of environmental chemical exposures. Thank you very much.
Thank you, Dr. Ballinger. Our next speaker is Dr. Avi Reichenberg. Dr. Reichenberg is Professor of Environmental Medicine and Public Health and Psychiatry at the Icahn School of Medicine at Mount Sinai. Dr. Reichenberg received a BA in psychology and a master's and PhD in neuropsychology from the Hebrew University of Jerusalem. An epidemiologist and neuropsychologist, his research aims to identify predisposing risk factors and risk periods to psychiatric disorders, including autism and schizophrenia. He's used epidemiological research methods and large population-based cohorts in the United States, the UK, Israel, New Zealand, Australia, and Scandinavia for over 20 years. He co-founded the Israeli conscript cohort, a longitudinal registry-based population study of 1 million Israeli adolescents that are being followed up for psychiatric outcomes through national health registries. He led the first study demonstrating the effects of advancing paternal age on autism risk, and he established the International Collaboration of Autism Registry Epidemiology, or ICARE, which is currently funded through the NIH Autism Centers of Excellence program, and he serves as the principal investigator for the center. Welcome, Dr. Reichenberg.
So, I need to manage this a little bit somehow, or not. Yeah, now it's working. Thank you all for being here this morning. It sounds like I travel a lot to those exotic places like New Zealand and Sweden and Europe. Usually we just sit in front of a computer and spend a lot of time querying into data. And what I will try to do today is talk to you a little bit about what we think right now causes autism and where we think some gaps exist in the literature. And this is for people who do autism research, and for parents, this is one of the most alarming figures ever presented. This is the increasing prevalence in autism across the United States and worldwide over about 30 years. You can see that in the 1970s, 1980s, everyone was talking about a very, very rare condition that was seen in 4 every 10,000 children. And over the years, the rates just kept going up and up in different countries, including in the US. The most recent estimate from the CDC surveys suggests that 1 of every 68 US children will be diagnosed with autism or spectrum disorders up to the age of 9, which is one of the most common childhood psychiatric or neurological disorders we are aware of. It's a lifetime condition. There are no known pharmacological treatments. There are some suggested behavioral treatments, but they do not help all the kids. So from the perspective of families, this is a very difficult condition to deal with. When you hear about autism, you hear that this is a genetic disorder, or it's a highly genetic disorder, and the reason for that comes from studies that more or less look like this. This is a twin study, and using twins, researchers often are able to estimate how much at the population level is in the risk for a disease is accounted for by genetic factors and how much is accounted for by environmental factors. And the way that they do it always sounds magical, but it's actually very, very simple. And you can be, for the sake of this morning, the amateur geneticist and actually calculate the heritability of autism, and this is how it's being done. So what you see here, this is the largest known study of twins with autism. And each one of these boxes represent a pair of twins. On the left are all the monozygotic or identical twins. These are twins that share 100% of their genetic material. They are clones of each other. It's one way of thinking about it. They are entirely identical from a genetic point of view. And on the right, you see the dizygotic twins, which share 50% of their genes. They are the same as 2 siblings, but they are born at the same time. And the extreme right is dizygotic twins, which are of opposite sex, so a male and a female. In the middle are dizygotic twins of the same sex, males or females. And each red box is a case that was diagnosed with autism or autism spectrum disorder. And then the question was, or is, what are the chances of his or her co-twin to also have autism? And you can see a very, very clear pattern, that the chances of a co-twin from the monozygotic or the identical twins is considerably higher than the chances of a co-twin from the dizygotic twin pairs to have autism as well, if one of them has autism. Now, when that happens, geneticists will interpret this as there is a genetic contribution to the disease, because MZ twins share 100% of their genes, DZ twins share 50% of their genes. If there is more similarity, more concordance among MZ twins than among DZ twins, genes are contributing to this disorder. And you can actually calculate how much of the risk or how much of the disease is caused by genes. This is done by a very simple formula, which I've oversimplified, but it's pretty much the way it's being done, is if one twin who is identical has autism, what are the chances of the other one to have autism as well? And the answer is, in this study, 40%. This is the concordance rate for MZ twins. And the same question is asked about DZ twins, and the chances here are 8%. The difference between these two proportions multiplied by 2 are a good estimate of how much is caused, how much of the risk for a disease is caused by genes. So if you do the math here, you get to more than 60% of the risk of autism that is caused by genetic factors. And this is more or less what the general estimate would be. It ranges between 60% to 80% in different studies, because there are different mathematical assumptions behind it. But if you wanted to be an amateur geneticist for this morning, you can do the math yourself, and you'll get an estimate for a disease that is caused to a large degree by genetic factors. But the same study actually gives another important thing that we need to think about. MZ twins are identical. They share 100% of their genetic maps with each other. Yet, so many of them do not go on to develop autism. So the genes are not enough. It's not just about genes, it's also about the environment. And many, many times when people talk about autism and talk about twins, they do not mention that part of the equation. The fact that twin studies also tell you when the environment is very, very important. We are in the era of molecular genetics, and there are now starting to be several studies that actually use measured genes to try and identify what are the causes of autism. And this is the first one of them. It used about 500 autism cases and 2,500 controls. All were genotyped using molecular genetic modern methods. And what the authors tried to do was, using molecular genetics, actually measuring the genes, which we don't do in autism. In autism, in twin studies. In twin studies, we are just using some statistical assumptions to estimate. Here, we are looking at the direct measurement of genetic factors in autism cases, and they tried to build a slightly more precise model of how much are genetic factors contributing to autism versus how much is the environment contributing to autism. And what they're showing here is that there is a very substantial contribution for environmental factor in autism. This is the blue part of this slide. They broke down the genetic components also to factors called as de novo mutation, large effect genes versus smaller effect genes, a common variation. But this is less critical right now for this morning's talk. It's just that what they're showing very neatly here is that there is clearly a very important role for environmental factors. And unfortunately, we haven't been doing a very good job, I think, in terms of finding those environmental factors, because there are so many potential environmental risk factors, and we are being very much behind in terms of studying them in environmental epidemiology, in psychiatry, and in neurology in the relationship to autism. I'll start by giving you an example of why maybe it's a lot more difficult than we expected. So a few years back, there was a report published in JAMA Psychiatry, one of the most prestigious journals in psychiatry, reporting on an association between the use of antidepressants during pregnancy and risk for autism in the offspring. And between 2 to 5% of pregnant women use antidepressants to treat depression during pregnancy. It's a medical condition that requires treatment. And until this paper came out, there was no knowledge about a relationship between antidepressants and autism. But what they reported, this is a study from California, with a relatively small sample, was of about a twofold, 100% increase in risk for autism in the offspring of mothers that were taking antidepressants. That was, made a lot of buzz in the media, and a lot of people started being very worried about it. So there were other studies. This is another study, this time from Sweden, published in the one of the two most prestigious European medical journals, the British Medical Journal. Here they were looking at reports by pregnant mothers on whether or not they were taking antidepressant medication during pregnancy, and they also found an association between medication exposure during pregnancy and risk for autism. In terms of the number of cases of autism that could be accounted for by use of medication during pregnancy, this only goes to about 1%, so it's not a major impact on the number of autism cases, but every family that has a case with autism is a family that has a case with autism. That didn't stop there. The New England Journal of Medicine has published another study from Denmark showing an association between the use of antidepressants during pregnancy and risk for autism. Their conclusion, I think, is one of the most confusing ones ever to be published in a medical journal, which is, you can read it yourself, we did not detect a statistically significant association, but it may still be dangerous. That means that more studies are definitely necessary. So there is another study from Denmark on the same birth cohort by other researchers showing no association eventually in their last model between antidepressant use and risk for autism, which should mean to all of us that if this is the best study that was done in terms of methodology, then we should all relax, calm down, and not worry about antidepressants. But here is another study. I think it's from Denmark again, this time showing even higher associations than before of every other study. It's for the same birth years, by the way, as before. So even I would get confused of that list. So we need to probably do a better job, and we have to remember that epidemiological studies, as good as they can be, have certain limitations. And there is some exciting work that's being done here at Mount Sinai, and that Dr. Aurora will speak about a little bit later, that hopefully will help us deal with some of the challenges of this methodology. But later on you get exciting. Now you get to one of the, I'll talk a little bit about one of the most boring, at least in the, to many of us, including myself, methods in medical research, which is a meta-analysis. So a meta-analysis is a way of integrating data already published and trying to find an answer for exactly this kind of a problem. You've got different findings from different groups with slightly different methods, and you try to convey a message to physicians, to parents, to the public, to policymakers. How do you do it in the face of such confusing results? You've seen what the results are for antidepressants and autism is just as an example. And a meta-analysis is not fun. It's not exciting. There are no great, beautiful figures. There's no brain imaging involved in it. There are no sophisticated statistical methods. It's a hard work going to the library, pulling out all the studies, reading them actually, deciding how good they are, putting them all together, integrating this with some statistical tools, and then trying to come up with some conclusion. And there is a second tier of these kind of methods where you assume that a risk factor is an important enough risk factor if somebody already published a meta-analysis about it, and then you go and you pull out these meta-analysis and you try to get a picture of what is the state of the art of the knowledge on a certain topic in medicine. And postdoctoral students of ours have tried to do just that about environmental risk factors for autism. And he searched all known narratives or all published papers that mention somehow the word systematic review or meta-analysis and environmental risk and autism, and came up with that very large number of approximately 627 potential studies that cover over 100 different risk factors, and then started going through these large number of manuscripts, trying to find the ones that can actually be included, and ended up with about 22 of them. And this is how it looks at the end. I told you, no colors, no bells and whistles, extremely boring and long, but very, very, very important, because it gives us two important messages that we can try and convey. One is how much more work needs to be done, and what can we say already about risk factors. So I listed 4 of them here, and the top one is valproate. It's medicine given to people with epilepsy. According to this meta-analysis and the knowledge we have about its toxicity, it is a very strong risk factor for autism. This is folic acid supplementation. It's marked in blue because it has been suggested as a potentially protective factor for autism if taken before pregnancy. There is some evidence in favor, some evidence not supporting this hypothesis. I think that currently the state of knowledge is that the jury is still out on whether it is actually protective or not. Either way, folic acid is very good. It's very healthy for other neurological conditions that may develop in the offspring. So, if anything, it will be also helpful for autism. Omega-3 fatty acids, again, a potential nutrient, no evidence. And another potential risk factors that had been in the news, which is assisted reproductive treatments, or IVF or ICSI. There's currently no evidence that overall IVF itself increases the risk. There is some evidence that certain treatments for infertility in males might be increasing the risk for autism. But even there, it's not conclusive. I think this one is unfortunately repeatedly being discussed. This is the MMR vaccine, or vaccinations in general, where the evidence from these meta-analysis clearly shows that there is no association between vaccination and risk for autism, but unfortunately this keeps coming up again and again and again. The interesting thing from this meta-analysis is that, if anything, it's actually protective somehow, and receiving vaccination reduces the risk for autism. Now, what we tried to do in order to put this in a slightly more colorful way, in a more clear way, is to put these risk factors in a context, I think, a little bit similar to the way you were trying to show population-based attributable risk or fractions and how to think about them. So this is somehow keeps jumping to the left. So we are talking about the exposure frequency. On the right are common exposures, such as lead, such as air pollution, for example, and the 80% is supposed to be over there. And on the left, you have very rare exposures. And the y-axis, what it tells us is whether it increases the risk and by how much, a lot or a little bit, or whether or not it can be protective. And we tried to put the risk factors where there was some consistent evidence out of those 100 on this potential map to tell us what are we supposed to worry about and how important are they. And of the 100 that were looked on this map are the ones where there is enough evidence to convince us that we can put it on. And this is what we got. So the strongest risk factor to date that we know about is valproate. The increase in risk is about a 4 or 5-fold. And you can see other potential risk factors mapped to it. Maternal diabetes, either before or during pregnancy, may have an association. At least currently, this is what the meta-analysis was suggesting. No association with maternal smoking. Folic acid, as I said, still not there, and probably vaccination is actually protective in the current society. Assisted reproductive treatments, particularly IVF, even though it's rare, it does not seem to increase the risk for autism. So if there is some knowledge and some positive things that I can show you today, I hope this figure conveys it. Thank you very much.
Thank you all. Those were really terrific presentations. We are now going to take a 15-minute break. If you have questions, please jot them down on your note cards and submit them to the check-in table. And please head back into this room by 10:35. We'll start promptly at 10:40.